lifespan up to 16 years. Early CKD, if diagnosed, then it reduces the lifespan by 6 years. If patient has diabetes, it can reduce the lifespan by 10 years. And if there is early diabetes kidney disease, it can reduce lifespan by 16 years. These are the renal effects of SGLT2 inhibitors. They can reduce the intraglomerular pressure, they can reduce the glucose levels in the plasma, they can reduce the blood pressure, they can reduce the volume, they can reduce the inflammatory markers, they reduce the microalbuminuria, they reduce the oxidative stress. And we have a very famous trial available on the CBOT trial of empagliflozin, with the name of EMPA-REX trial, very famous trial. जब empagliflozin launched, this was a sole trial available, जिसको सबसे ज़्यादा मार्केट किया गया था उसको के लिए. तो इसके जो रीनल आउटकम्स हैं वो मैं आपसे शेयर करूंगा, और जो इसके जो कार्डियोवास्कुलर आउटकम्स हैं वो डॉक्टर कामरान बाबर आपसे शेयर करेंगे लेटर ऑन. सो मैं जस्ट आपसे रिजल्ट शेयर करूंगा कि जितने भी पैरामीटर्स हैं, दे वर improved by using empagliflozin, like incident of the worsening of the nephropathy, or the incident of the worsening of the nephropathy or the CV death, or the worsening of nephropathy or progression to the microalbuminuria, or doubling of serum creatinine and EGFR, initiation of renal replacement therapy, and doubling of serum creatinine and EGFR, which was less than 45, renal replacement therapy. So all the markers were improved. They were in favor of empagliflozin during the trial. The incidence or worsening of the nephropathy was reduced by empagliflozin in comparison to the placebo. In the post-hoc renal composite outcome, the same results were seen, that it was improved by empagliflozin in comparison to the placebo. Renal outcomes with empagliflozin over 3.2 years, the incidence or worsening of the nephropathy was reduced by 39% in comparison to the placebo. Post-hoc composite outcome was reduced by 44% in patients who were using empagliflozin, and similarly, the progression to the microalbuminuria was reduced by 38% in the patients who were using empagliflozin. So all these results favored the use of empagliflozin in CKD patients. If you look at the guidelines, जो guidelines हम use कर रहे हैं, चाहे वो ADA guidelines हैं, ACE हैं, ESE guidelines हैं, almost सबका एक ही, then consider SGLT2 inhibitor, or patient has increased risk of ASCVD, then use SGLT2 inhibitors or the GLP-1. If the patient has high risk of CKD, then start with SGLT2 inhibitors. If contraindicated for any reason, then you may give GLP-1 receptor agonist. People with high risk or established CKD use metformin when you can. एक ये भी concept है कि जी अगर creatinine 1.3, 1.4 पे हो गया तो हम बस metformin को बंद कर देंगे. No, there are guidelines available. If the eGFR is above 55 or above 60, you can use the optimal dose of metformin. If it is between 55 and 45, you can still use the optimal dose of metformin, that is 2 grams. But with caution, you need to check the eGFR and the creatinine periodically. But if it is between 30 and 45, you need to reduce the dose by 50%. And if it is 30 or less, then you need to stop metformin. If the creatinine has started raising, हम बहुत सारे लोग हम में से बिल्कुल metformin को बंद करते हैं. We can use metformin, लेकिन ये कि उसको हम repeatedly check करते हैं creatinine को भी और eGFR को भी. So use metformin unless it is contraindicated or not being tolerated. If the patient has CKD or diabetic kidney disease or albuminuria, preferably SGLT2, with primary evidence of reducing CKD progression. तो इनमें से सारे SGLT2 inhibitors ऐसे नहीं हैं जो कि CKD के अंदर वो recommended हैं. जो इनमें से recommended हैं, like empagliflozin और dapagliflozin आप use कर सकते हैं. Even canagliflozin पर भी data available है. Or using SGLT2 inhibitors with evidence of reducing CKD progression or in CBOT trial. अगर CBOT trial के अंदर भी उसका renal safety data available है, तब भी use की जा सकती है. अगर diabetic kidney disease नहीं है या albuminuria नहीं है, then आप eGFR 60 से ज़्यादा है और आप increased risk of cardiovascular event है, तब भी आप use कर सकते हैं इसको. अगर किसी वजह से कॉन्ट्राइंडिकेटेड है, कॉन्ट्राइंडिकेशंस कई आ सकती हैं कि जीएफआर बहुत रिड्यूस हो गया, तभी हम इसको नहीं यूज करेंगे, या रिकरेंट हिस्ट्री है यूटीआईज की, तभी हम नहीं कर रहे होते हैं इसको. तो मल्टीपल कॉन्ट्राइंडिकेशंस आ सकती हैं.